Good morning, good afternoon, good evening. I'm delighted to welcome you all to this webinar focusing on family planning high impact practices. The practice that we will be looking at together today is social franchising, improving the quality and expanding contraceptive choice in the private sector. And webinar is jointly presented by the IBP Initiative and FP 2020. Now, the social franchising high impact practice is a brand new HIP that was published in March of 2018, but it's not a new practice, of course. There's been a significant expansion of social franchising or family planning social franchising over the last 10 years, and we're very lucky to be able to hear today from one of the authors of that brief and indeed two colleagues who are implementing social franchising programs in key countries, Ethiopia and Myanmar. I'm Martin Smith. I'm the Managing Director here at FP 2020. It's a subject very close to my heart, social franchising. I've been involved in setting up social franchising family planning programs in Africa and Asia during the last decade. Next slide, please. So our webinar is in 4 parts. We're doing some welcome and introduction that we're right in the middle of at the moment. We will move into 3 presentations that I will detail in a couple of minutes' time. Then we have a critical question and answer session, and we'll talk about the question box on the right-hand navigation of your webinar, but we will be going into Q&A for about 20 minutes from 10 past 10 Eastern time in about 38 minutes from now. And then there'll be a few closing steps that I'll take us through. But before we begin, just to remind all of you that this webinar is being recorded, and I'll tell you all about where you can find the recording at the end of this webinar. You can submit your questions at any time in the questions section on the right-hand dialog box that you can see in the GoToWebinar software. There is a handout section that you'll also see in this navigation. There are 5 handouts, including the brief itself and some key implementation documents from our colleagues at PSI Myanmar. And importantly, the website, of course, fphighimpactpractices.org. So let's shift on very quickly to our main presentation. And as I say, social franchising, improving the quality and expanding contraceptive choice in the private sector. The next slide, please. And we will move through these quite quickly, just to remind you all, what are high impact practices? Well, they are, of course, evidence-based family planning practices that are vetted by experts and documented in an easy-to-use format. At the moment, there are 20 of them, including this new social franchising HIP, as well as an evidence summary and a strategic planning guide. So there are 22 key documents that you'll find at that website. They're used for advocacy purposes, for strategic planning, program design, research gaps, and a range of other options, including to support implementation of the practice itself. Now, there are 3 categories, 3 primary categories of HIPs. There are enabling environment, high impact practices. There are service delivery HIPs, of which this social franchising is one, of course. And there is a relatively newer category, an expanding category of high impact practices, which is those around social and behavior change. There are also a range of HIP enhancements as well, which are used in parallel with the 3 categories I've set out. Next slide, please. So, of course, today's webinar is focusing on social franchising, which is in the service delivery group that I outlined just now. And this brief is rated as a promising practice. So there is some evidence, although it is still relatively limited, and more information is certainly needed to document implementation experience and impact. And a lot of that implementation experience is coming from colleagues like Daniel and Tesfaye, who we'll hear from during the course of this morning. The High Impact Practices Technical Advisory Group recommends that promising practices be promoted very widely and that they're implemented within the context of research and carefully evaluated in both impact and process. So quickly, our objectives for today, for you as participants to have a better understanding of the social franchising HIPS brief and social franchising overall, and for that sharing of implementation successes and challenges in using social franchising both at the global level and most importantly at the country level. A couple of quick overview points will come from me in just one moment, but before we get into that, we thought it would be a nice idea for us to start with a quick poll. And we're going to go through, and we're going to take about 30 to 45 seconds for you to answer this this key question, and that is that I, as a participant in this webinar, know the difference between social franchising and social marketing within family planning programs. So please vote from your perspective whether you know that difference or you do not, and please vote now. I can see the voting is going on very well, and we're going to have the result up on the screen in just a few seconds. And we're having a very good response rate, and it's changing by the second. We're just going to give it another sort of 10 seconds or so, I think. 83% of you have voted. So very good response rate. Thank you for that. And I think we're almost there to now close the poll and display the results on the screen. And thank you. So 66% of you, fully 2/3 of you, know the difference in terms of social franchising and social marketing. Social marketing is a high impact practice as well, of course. 34% of you, 1/3 of the group, either perhaps don't know or could do with a little bit more clarification. So certainly I'll just give from my perspective the difference here. So both, of course, refer to engagement with the private sector, with private providers. Here, of course, with social franchising, we're referring to the organization of those private providers into branded, quality assured networks to increase access to largely provider dependent contraceptive methods and related services. Social marketing, of course, makes contraceptive products and increasingly, in many cases, services accessible and affordable through private sector outlets using commercial marketing techniques to achieve specific behavioral goals. And the two can work in close conjunction, of course. So I'm going to move on, and thank you very much for that great participation in the poll. So as I say, just a couple of other framing points from me. Knowledge and evidence is one of the 4 key FP 2020 pillars. So engaging with the community around the high impact practices is a very significant part of my work, is obviously a very significant part of the work of the IBP initiative as well, of course. We're working with countries to identify key strategic points to integrate these high impact practices in the commitments countries make, in the costed implementation plans they develop, the roadmap to how those commitments are going to be reached, and indeed to action plans which FP 2020 focal points develop in country. FP 2020 has a HIPS advisor on staff here, Laura Rainey, who helps to strengthen the engagement with the FP 2020 focal point structure, government donors, and indeed civil society focal points who link in very closely with the wider civil society family planning community in all the FP 2020 countries. Next slide, please. So just quickly, when we look at social franchising across the 42 countries that have made commitments to FP 2020, fully 5 of those countries make very specific reference to social franchising in the commitment they made to FP 2020, and you can see the 5 countries listed here. 10 countries, there's some overlap of course, make reference to social franchising in the costed implementation plan as a way of operationalizing around that commitment. And a further 7 countries make specific reference to immediate actions they're going to be taking on social franchising in their action plan. Now, if a country isn't on this list, of course, it doesn't mean that social franchising isn't a key part of the family planning landscape in that country. These are the countries that are perhaps coming to social franchising afresh or are coming to social franchising with a new approach. And it's going to be great to hear from two countries, Myanmar and Ethiopia, that are perhaps more well established in their family planning within social franchising during the course of this webinar. And so on to my final slide before we really get going into hearing from our panelists. Next slide, please. So today's panelists, we have an array of insights from three excellent speakers. Firstly, we'll hear from Sarah Thurston, who was the co-author of the HIPS brief. Sarah is a senior technical advisor at Population Services International's SIFPO2 project. After Sarah has spoken, we're going to hear a recorded presentation from Daniel Crapper. He's the Deputy Country Director of PSI Myanmar, very late at night in Yangon, of course, but we're very lucky that Daniel has recorded his presentation. And thirdly, we will hear from Tesfaye Mesele from MSI Ethiopia. Tesfaye is the Director of Private Sector Support and Informatics. So without further ado, great to hand you over to Sarah Thurston to take us through the social franchising HIPS brief. Over to you, Sarah.
Great, thanks, Martin. Hi, everyone. As Martin just said, I'm Sarah Thurston. I'm a Senior Technical Advisor for Family Planning here at PSI. And I'm also one of the authors of the Social Franchising HIP Brief. So what I'm going to do today is share with you just a short overview of the brief itself. Next slide, please. So as many of you know, and as Martin just alluded to, social franchising has grown really exponentially over the last 10 years or so. From just sort of a handful of programs a decade ago, there's now over 70 active social franchise networks globally, with the majority of these in sub-Saharan Africa and South Asia. And social franchising is now one of the major mechanisms for increasing access to FP in the private sector. And this is especially true for clinical FP services like IUDs and implants. So with the practice well underway, the HIP Technical Advisory Group felt like it was the right time to develop a brief in order to provide the community of practice with a critical review of the evidence that's summarized in an easy to digest format, tips on implementation of the social franchise practice, and then also, as Martin mentioned, the TAG's recommendation that as a promising practice, social franchising should be promoted widely, but within the context of research and rigorous evaluation. Next slide, please. So the brief itself begins by explaining the problem that social franchising works to address. And what this is that despite the fact that private providers in many markets are a common source of family planning, many of these providers aren't able to offer a broad range of family planning methods, especially voluntary LARC methods. And this is due to a number of reasons. It could be out-of-date training, poor access to commodities, or a host of other factors. But this is really a missed opportunity to leverage the existing health infrastructure to expand access to FP and other high-impact health services. So just quickly, what does social franchising as a practice look like? Who's involved? What are they doing? Social franchising includes a franchisor. This is typically a non-governmental organization like PSI or MSI. And the franchisor recruits independently owned and operated private clinics to participate in its franchise network. So once a clinic joins the network, they sign an MOU with the franchisor. And through this MOU, agree to deliver specific services called the franchised services. And these, in the case of family planning, social franchising, are a broad range of family planning methods. And they agree to deliver these services at prescribed high quality standards. But to support this, the franchisor works with these clinics, offering them a range of support inputs like clinical training, supportive supervision, support for family planning awareness raising in their catchment area, and in some instances, support to improve their business skills, record keeping, and the like. Next slide, please. So the bulk of the HIP brief on social franchising is dedicated to summarizing the evidence base on the practice. So as with other briefs, we, the authors, focused on evidence from peer-reviewed published studies, but we did also broaden out our review to include some unpublished information, such as MIS data from large franchisors like PSI and MSI. So in a nutshell, I'm going to summarize 5 evidence points that the brief points to. The first is that social franchising improves the quality of clinical FP services. So we see that clinics that are part of a social franchise network score higher on quality assessments than those that aren't part of a social franchise network. The second is that social franchising increases FP client volumes for clinics participating in the network. The third is that social franchising supports increased utilization of voluntary LARC methods as part of a method mix. So the evidence shows that women living in catchment areas served by a social franchise facility are more likely to be using a LARC method as their FP method than women living in an area not served by a social franchise facility. It shows that social franchising can improve FP access and uptake for underserved groups, including young people and the poor. And then finally, that social franchising may increase MCPR at the population level. But on this point, findings are mixed, and the community of practice really does need more research to dig into this question. Next slide, please. So the HIP brief also highlights top tips from implementers. 3 important ones that I'll highlight here are that franchisee clinic selection really matters a lot. In order to have the maximum possible impact on FP outcomes and quality, social franchise facilities should be located in places that serve high-need populations. And franchisors need to find providers that are really motivated to add new services like LARC methods and to improve their clinical quality, because this does require behavior change on their part and a lot of effort, honestly. The second point is that combining social franchising with demand-side interventions like voucher programs have proven very successful across a number of contexts for increasing both access and equity of FP. And then finally, the third tip from the implementers is that when we think about what types of services we should franchise, it makes sense to consider franchising and supporting a range of primary care services, including FP, but not limited to FP. And this broader range of quality assured services is really something that may better facilitate clinics linking with domestic financing opportunities like national health insurance programs. Next slide, please. So in conclusion, there's a lot of great learnings about the practice of social franchising that are outlined in the HIP brief, but there's also some key things we don't know yet as a community of practice, and the HIP brief outlines some of these priority research questions. One of these is the question of cost effectiveness and how we measure this question in a uniform way across franchise networks in order to compare social franchising with alternative FP interventions. Looking forward to the practice of social franchising, there's a couple of emerging trends that I'll just wrap up with here. One trend is that the sort of traditional social franchising approach is becoming really more flexible, and we're seeing it adapted to the needs of different country contexts. So as an example from PSI, in India, PSI supports networks of private providers. But quality assurance and the actual support are done by the Ministry of Health, and PSI plays a facilitation role in this. But in another country, for example, Uganda, PSI takes a much more hands-on approach to doing the actual clinical training and supportive supervision ourselves. And we do this in consultation with the MOH. So adapting the model to the needs of the health market. The second trend is a desire, and in more and more contexts, I would say a reality, to link social franchise facilities into domestic public financing programs. And this is a way to integrate the private sector into the broader health system, but also a way to allow these private providers to serve a broader range of clients. So my colleague Daniel is going to provide in the next presentation a really great example of this in Myanmar. So I hope everyone has a chance to read the brief. In addition to its content, it provides a list of additional resources to find out more about social franchising. And one in particular is the e-learning course, which is highlighted here with a link at the bottom. So with that, I will wrap up and say thank you. We have up next my colleague Daniel Crapper, Deputy Country Representative of PSI Myanmar. And as Martin mentioned, due to the time difference, Daniel has pre-recorded his presentation. So we will start that now.
Hello and welcome to this presentation. Today I've been asked to talk about how we are using innovative financing mechanisms to help improve health outcomes and increase access to family planning in the private sector here in Myanmar. My name is Daniel Crapper, the Deputy Country Representative of PSI Myanmar. I'd first of all perhaps like to draw some attention to the wide range of donor logos that we have at the bottom of the slide. We have at least 3 USA projects that are supporting our activities and a wide range of other donors. I'd also like to draw attention to the Ministry of Health and Sports logo at the left, because our project is being implemented in very close partnership with the Ministry of Health. It is, of course, the Ministry of Health that has set out a very bold vision for achieving universal health coverage here in Myanmar by 2030. But of course,
I'm just going to intervene here for a second. Martin Smith here. I'm getting very low volume from Daniel's presentation. I'm pretty sure the rest of you probably are as well. We're working with my colleague Ados May. Ados, I wonder if we can perhaps just quickly zip back to the beginning of Daniel's presentation and see if we can pump up the volume a bit. So that we can hear what he has to say very well.
Daniel, I'm sorry, Martin. The volume is at the top. Is the recording?
Okay. Then I think let's go back to the beginning and see if we have a better volume second time around. Thank you.
Okay.
Identified 3 key challenges. They include low health service coverage, high financial risk, and inequalities in access to care. It is in this project that we hope to address all 3 of those issues. An opening question may be, what exactly do we mean by strategic purchasing? I think it's a valid question and one that I had to ask myself when we set out on this project a couple of years back. Strategic purchasing involves identifying the particular provider payment mechanisms that will generate the right incentives needed to achieve the kind of health outcomes that we are looking to achieve. As we use strategic purchasing, we must be ready to continuously adjust these incentives as we monitor changes in provider behavior. The process of strategic purchasing will always look at what interventions we'll be ending up purchasing, how they should be purchased, and of course, who we would end up purchasing from. In our case, we are looking at purchasing services through the Sun Quality Health Network, which is a primary healthcare franchise that has been operating here in Myanmar since about 2001. Today, we have around about 1,200 primary healthcare providers in this network, primarily in urban and peri-urban areas. This network is all based on independent private general practitioners. They're offering a wide range of primary healthcare services, communicable and non-communicable diseases, and of course, a wide range of modern family planning methods. So our hypothesis is that we can use strategic purchasing arrangements to improve health and family planning outcomes for low-income clients and achieve good value for money for public subsidy. There are three things we've set out to show. One, that we can increase the range of services that are provided, that we can decrease out-of-pocket payments, and we can reduce delays to seeking treatment. I'm pleased to say that we are making good progress in the first two of these objectives, though unfortunately the third one we've yet to demonstrate, but we will keep trying. So under this project, what exactly does this mean for Susu? Susu is our archetype of a typical young Myanmar woman who's has a young family with some small children. Under this project, if you are lucky enough to be chosen as a beneficiary, you'll be issued a health card that will allow you access to a defined package of health services at a nearby participating clinic of your choice. That clinic will be close to your community. It will offer a wide range of family planning options, as well as basic primary healthcare treatment. The provider will be friendly and sympathetic, and you should be able to access care without financial hardship. And for Dr. Myat, who is one of our contracted providers, he knows that he has been contracted with a fair monthly fixed amount, which is issued based on the number of cards that have been issued to beneficiaries. When a patient arrives and shows him this card, he knows to offer them any service on the agreed service package at a heavily discounted price. And that service will be offered at the same level of quality as any other paying customer would receive. In addition, assuming he achieves certain indicators around quality, patient satisfaction, and participates in certain preventive care services, which of course could include family planning, you will receive an additional quarterly incentive. And what does this mean for the government? Well, the government is currently formulating its health financing strategy. Within that strategy, the government has defined that it wishes to establish a purchasing entity that would be able to contract with a wide range of different types of provider, including private providers. So under our project, because this purchasing entity does not yet exist, PSI is simulating the role of that purchasing entity, learning lessons and documenting the lessons in a way that the government, we will hand over the lessons to the government, so that once this purchasing entity is formed, that will be a central function of government, and PSI may act as an intermediary between the purchasing entity and some of the private providers that we are serving. How have we gone about this project? Well, we identified early on that there were 5 key steps that we had to address. We had to define a package of services. We had to identify who would be the beneficiaries. We had to calculate the monthly capitation amount, as well as define a set of pay-for-performance targets that would address some of the perverse incentives that a monthly capitation amount might introduce. And of course, we had to design a medical record system that would monitor the data around this project. At the same time, because we defined this as a project of creating learning for the government and a future purchasing agency, we adopted an implementation research approach that asks, every quarter we sit down and ask a set of questions, we go out and research it, and we report back. The people we're reporting to is the National Scale-Up Committee, which meets quarterly and consists of the Government of Myanmar, various donors and NGOs, and of course the private Myanmar Medical Association. The Scale-Up Committee has met so far 4 times since it was established. The last meeting was just in this last week. This is the essential package of services. I won't go into too much detail, but I would like to highlight the wide range of family planning services. It's a core package that all providers will provide, but there are some enhanced enhanced value-added services that only certain providers might be certified to offer, such as long-term methods or cervical cancer screening. And so there would be each client would be able to be referred to a provider offering the enhanced package. An important question: have we managed to reach poor people? I think that we are reasonably satisfied with the results. We have mainly reached people from the bottom 3 quintiles in our pilot project in Yangon so far. I think we're, as I said, fairly satisfied with this result. One of the most important questions is, are we actually reducing the costs, the out-of-pocket expenditure of the beneficiaries? What we have identified is that not all our clients are using our card, and that has helped us establish almost a mini control group within our project. Those who have opted to use their card, we've identified a significant reduction in the out-of-pocket expenditure that they're incurring compared to those who have opted not to use the card. And the same results we found across family planning services. So those who are accessing family planning services are also achieving a significant reduction in cost. I think that's one of the main outcomes that we've demonstrated from this project so far. Our project is still small. We've so far contracted with 7 providers, and I have to say we've also removed 2 of them, one of whom was shown to be treating some of the beneficiaries worse than he was treating his normal paying customers. This was unacceptable, and luckily, fortunately, we have the monitoring systems in place that was able to identify that, and we were able to move that particular provider. We've over 10,000 beneficiaries, and so far our cost per capita for delivering the services is under $1. It's about 65 cents. This is about $7, between $7 and $8 per person per year, and we think these are a reasonable amount of costs that is affordable to the government of Myanmar, or will be affordable to the government of Myanmar. Those costs don't include yet the management costs. This being a pilot project, those are still relatively high, but as were we to scale this project up, those management costs would become a reasonable proportion of the total cost of the project. So overall, what are we learning? What have we learned? I've talked the first 3 there. I think I've gone through. We've learned a lot about the need for communication and engagement. I perhaps haven't quite mentioned the challenges of communicating a relatively complicated set of financial arrangements with the doctors, the clients, and of course the community. One of the biggest lessons we learned, I think, out-of-pocket expenditures, a big part of those out-of-pocket expenditures are travel costs, and we really need to make sure that our providers are in extreme proximity to the beneficiaries we're trying to serve. One of the biggest lessons perhaps we've learned is that we need to develop a much stronger community outreach component, and all our future activities will have that strong outreach component. When we set up our capitation payment, it was based on modeling of an expected number of expected disease profile, and of course an expected number of visits per person per year. We modeled around 4 visits per person to be cautious. In fact, we were achieving less than 2 visits per person per year. This means that we need to keep adjusting our financial model, and we are continuously doing that. We managed to lower costs quite considerably based on a more realistic number of clinic visits. We have, of course, learnt a number of lessons around contracting with providers. We learned a lot around our costs and around the kind of incentives that may need to be offered and provided in order to minimize some of the perverse incentives that naturally arise in a scheme such as this one. I've really rattled through many of these lessons learned quite quickly. I'm proud to say that we've documented in quite a lot of detail many of these lessons in a series of learning briefs, which I would encourage you to look at online if there's any level of interest that I've stoked today. These are on PSI, www.psi.org publications, and the Myanmar UAC brief series. I think that's where I'll stop. I'm going to run out of time. I'd like to say thank you much for your attention. Here are some pictures of our project in Chim State. Thank you, and good night.
Tesfai, over to you. I hope you can hear me okay.
Yes, thank you, Martin. My name is Tesfai Msele. I'm a social franchise program lead for Medsofts Ethiopia. Thanks for my colleagues, the panelists. They walk you through various types of SF model, definitions, and the impact, and as well the FP 2020 commitments. I would like to mainly focus on the sustainability aspect of franchise program, how we could ensure the sustainability of social franchise program with a structured capacity program journey to make them independent. I would like to start my presentation just giving you a brief background about social franchise program in Medsofts International Ethiopia. Actually, we franchise in Ethiopia to improve the availability and quality of comprehensive SRA service, mainly focused on family planning. We are focused on strengthening the financial viability of our private sector's partner so that they become independent providers of high quality SRA services. Actually, we do not mean undermine the financial interest of private providers because the ultimate goal means they are established to make profit. We acknowledge that. And when it comes to our vision in general, we would like to see women in Ethiopia of their age, economical status, or different types of their status in the community. They have to have main access to quality service, and they have to have also choice of service and choice of provider. That's why MSI brought up different types of a service delivery modality approach, including this social franchise program. And we have also a maternity center and static clinics and outreach program. We call them a mobile team. And we have also a workplace program and social marketing as well. So we would like to have our beneficiary a choice of their provider. MSI actually run a fractional franchise program, or we call it a partial. And we are actually a pioneer for SF business in Ethiopia with the Blue Star brand. We the program in 2018, and different types of impacts have been shown for the improvement of women, men, and girls in Ethiopia at large. As you can see on the map of this slide, our intervention is across the regions in Ethiopia, everywhere except Somalia and Benishangul. And since we start the program, the number of franchised clinic or the provider working with us increased from year to year. And by mid of 2016, we were able to reach around 615 franchises work with our Blue Star network. Next slide, please. While we see our main journey with regard to the sustainability, one of the main approaches is a tiered structure. As it was presented on the title, we used on a structured capacity building journey to make them the private provider independently provide family planning services. At the end of 2016, MESA had a sort of an assessment about the journey from the beginning, and we came up with a revitalized strategy which takes into account the global Medsofts International Scaling Up Excellence strategy, which mainly focus on the scale and impact, quality, and sustainability. And after we do the revitalization of the existing social franchise program, we come up with a tiered structure, or we call it a graduation model. Next slide, please. MSI globally has a success model which holds everything we need to know about social franchise program in one place. Actually, we call it a recipe for success, and this model suggests a proper segmentation for proper resource utilization and also adequate response to the need according to the segment. So we use substantially, the success model guides and principles. It's really helpful and it's also one of the main factor to succeed in this franchisee business in MSI. There are, as you can see on the slide of this tier structure, there are 5 tiers of which there are 5 stages, and of which the 3 of them from Blue Star level 1 to Blue Star level 3 are under a Blue Star brand, and the topmost one is a graduated one. We call them a premium group, the one who are independent. And the lowest, the lower most one is the downgrade clinic. A clinic which are under a waiting list. We give them a 1-year period to improve their performance and rejoin the Blue Star network. So this allows us, a structured capacity building journey to make them independently offer family planning services. As you go up the tier, the capacity building program, which also include non-clinical aspect, mainly business skill training, and also how to plan to access loan from commercial bankers. Okay, so as we go up, we free up resources and then relocate those resources for the one who need our support much. Why we need actually this is there are a lot of reasons, but the main one is following our thorough evaluation of existing program. We learned that regardless of the time the clinic stay in the network and whether the clinic perform best or not or have good quality or not, we label them as just a Blue Star member clinic with a similar package across the board. So, but from the assessment, we learned that we need to make some correction around this, and that's why the tiered structure really motivates and aspire the provider to join to the next level, and it will become an indirect incentive to enforce quality improvement. Since we implement this revised structure, as of January 2017, we have seen very remarkable achievements in all aspects, quality improvement and the productivity of the clinic, and their also richness on the high impact clients, meaning the one who are marginalized or hard to reach. The importance of mainly having say types of model is we can free up as the clinic move up to the tier, they become less independent and so they can also be as used as a mentor and also a trainer for other peers or their colleagues. Next slide. As part of this sustainability journey for the social franchise program, we take into account the importance of this PPP or a public-private partnership. Regarding the government response towards a private sector engagement, as can see on the spectrum, it varied from government to government, from the one who resists and to the one who support and also contracting out the government activities or services to the private sector. While we see the Ethiopia government now in between about interested for the private sector, and it become currently also a supportive one because they launch development of a new private-public partnership guideline, mainly specifically for family planning and other RMLSH service. This clearly shows the interest of the government of Ethiopia, and they become supportive. This is not just simply it comes by its own, but due to a lot of advocacy activities, what we have been done so far. So MSI basically advocate this PPP mainly to pursue a stronger linkage with the government of Ethiopia to secure access to national supply chain for contraceptives and to establish a regularly framework that prioritizes clinical quality, because we can improve clinical quality joint a clinical quality improvement plan, and to demonstrate also the potential role of private sector meaning how they can play, meeting the needs of high impact group, mainly the poor and adolescent. We have been showing the impact of our booster clinics reaching adolescents. It's clear the proportion of adolescents go to our private providers or booster clinics is much higher than the one who go to the public provider due to various reasons, mainly to confidentiality and the others. So we have shown this also, and then the government of Ethiopia also take into account one of main a service delivery option for adolescents is a private providers. So this is also part of our advocacy. In general, inclusion of private clinics in a health insurance scheme will encourage a long-term sustainability of the service. As was mentioned, Sarah and as well Daniel and Martin in the previous presentations, we can link the private sectors through the health insurance scheme, and we can also show how a private sector impact reaching the unreached one or the poor or the adolescent through a demand side financing scheme. Next slide. Now, just to wrap up my main presentation with regard to sustainability. As I mentioned in the beginning, MSI has three main pillars as part of the 2020 strategy. Among the three, sustainability is the one. So for this sustainability approach, we consider sustainability as a continuity of a franchisee program with both franchisor, in this case is MSI, and franchisee, private clinics or blue star clinics. And the other aspect could be the continuity of service in the absence of the franchisor. In either of the case, our main goal is the continuity of the service provision and the beneficiary access to those quality service from the private providers. So with regard to sustainability approach, we come up with various main options, among which mainly related to diversifying the financing stream for our social franchise network through mainly establishing a cost sharing or a franchisee fee relationship at the beginning of the partnership. So we like to establish this partnership by building a kind of concept, no free lunch, everything has its own expense, though it's highly donor subsidized or donor dependent program. But once we build this relationship and they reformulate their expectation. Another one is with regard to a corporate contribution to workplace program. MSI has a workplace program. We call it a fit for work. So the employers are interested to pay for their employees' health payments. So we can also incorporate this contribution and have one of our approach. And the public contribution to private sector family planning, meaning shared supply chain for contraceptives. So this is basically through a public-private partnership. And the major one is about graduation model, which is a tiered structure and the structure capacity model, capacity building journey to make them independent. So this is really one of the main approach for sustainability and social franchise program. In general, we have to consider this aspect, meaning while we diversify the financing stream, we should also control our costs, so improve the cost efficiency. With regard to this, we did estimating or quantifying our investment to each clinic with regard to all the package. Actually, we have different types of package, so we do all these estimates and communicate to our franchisee or clinics. Okay, they have to consider that capital for their business running the clinic. So improving this business skill of the providers leads to a cost sharing, a franchisee fee, to a franchisor approach. So we provide different types of business skill training for all provider when they go up to the tier. And the one already mentioned by my colleagues is about a voucher or a waiver program. We have both programs, and we will and also supported by evidence. So this works also an important demonstration to the government that there are alternative to supply side financing for family planning services. That demand side financing can improve the efficiency while still supporting access among the support. So this is also an indirect incentive for our private provider to improve their quality service provision and access. Finally, I would like to say, in general, though, we have various types of approaches, and but as a model, we choose the three. The first model is the graduation model, and the second one is the franchisee pay to the franchisor, and the last model is a workplace program. We are actually at an infancy stage, but in 2018, we have seen very positive results with regard to all this sustainability approach. And in 2019, we will mainly focus and prioritize sustainability, and we will make our social franchise program sustainable in the coming years. Thank you.
Thanks very much indeed, Tesfaye, and thanks to Daniel and Sarah as well. So we're in the Q&A portion of our webinar now, and thank you so much for the excellent range of questions that have already are coming through. Please continue to type them. We've got lots to get through, and we're delighted that Daniel has joined us from Myanmar late at night there as we answer these questions. So one that's come through from several participants on the webinar, and I'm going to give just 10 seconds to each of our three presenters in a very quick fire fashion here. In your opinion, what is the most important factor for family planning within a social franchise to succeed? I'm going to do this quick fire, and I'm going to go to you first, Tesfaye.
Thank you, Martin. For me, the most factor which affect the success of the social franchise program is recruitment or selection of the franchisee or the private clinic. Okay,
right.
We should take into account whether we recruit or select the right type of clinic at the right location.
Great, fantastic. 12 seconds, pretty good. Selection of private providers for potential franchisees, excellent. I'm going to go to you next, Sarah. What's the most important factor in your opinion?
I'm going to cheat and say two. I think one, adequate resources for setting up the franchise or activities is obviously necessary. And then government support of private sector delivery of family planning is critical.
Adequate resources and government support. Excellent. And Daniel, are you there?
Yeah, yes, I am. What I would probably add to that is the getting the financing right. I've worked in maybe too many franchises where the long-term sustainability is damaged by the donor funding running out.
Yeah, great points from all three of you. So excellent. So let's get into a range of questions that are pouring through at the moment. And Daniel, I'm going to come to you first with these individual questions. From Sarah Holcomb, how did PSI establish the monthly capitated payment level, and how does this compare with government spending per capita in Myanmar?
Great question. We sort of did it two ways. One was what I'd call the intuitive way, where we just we sort of roughly said, we know roughly how much a typical consultation costs. We know we can predict how many visits there will be per year per person based on international averages, and we multiplied one by the other. The other way was a much more complex way, where we built a form of actuarial model using data from the DHS, data from the census, worked out an average profile of, say, 1,000 households, how many adolescents, how many youth, how many pregnant women there would be, worked out the prevalence of different diseases and contraceptive use, multiplied those all out, and then worked out again how many visits there would be per year, and roughly how much it would cost. And the two came to close enough answers that we sat with it. If you look at our learning brief number 2, I think it is, you'll see a much more detailed answer. You'll also notice that the number in there is much bigger than the number I put on my presentation. If you were looking at closely, it's because we've dramatically lowered the number of visits per person per year.
Okay, thanks very much indeed, Daniel. Hope that answers your question, Sarah. So a question now from Kate for Sarah Thurston. When you say, Sarah, that the evidence shows social franchising has higher quality, can you talk about how this is measured and whether those measurement methods are consistent across countries and programs?
Sure. Just a brief answer to that. And in the brief, there are more details. There are only a handful of studies that look at the quality issue around family planning. And unfortunately, each of the studies takes a different methodology. So it makes comparison a little bit difficult, but the studies compare franchising quality outcomes with private sector non-franchising quality outcomes and show that franchising outcomes tend to be more favorable. But then other studies compare franchising quality outcomes with public sector outcomes. And in some countries, we see that those two subsets are both high quality and comparable. And in other countries, we see that the franchised private sector has higher quality. So a little bit tricky because the methodologies are different and we're looking at different sectors across countries. But generally speaking, the trend is that with the inputs through social franchising to private sector clinics, we see not only higher quality in comparison to other sectors, but higher quality over time for the duration of the time that the franchise facility is participating in the network.
Great, thanks very much indeed. So Tesfai, over to you next with a question from Smarajit from India. There's national commitment to introduce social franchising at the national level in India, but states lack trust on private providers. What should the strategy be to get our states, governments convinced about the value of private providers and social franchising? Can you offer advice from the Ethiopian context?
Yeah, sure. Good question. Yeah, so I mentioned in my presentation, yeah, actually it was not easy. I mean, to build such type of trustful partnership between public and private or with the government. At the beginning, yeah, it was difficult. Our government also considered our private providers as simply they are established to make profit, and they are not worried about to increase access, or they are not fulfill the corporate responsibilities or social responsibilities. But later, through our partnership and advocacy process, we keep telling them the impact of the social franchise program and also those private providers, their quality as well as their impact and how to reach the adolescent. So mainly through advocacy to show them the impact of the social franchise program, and also to discuss with the government bodies the fee structure, how they are, okay, to what extent they are providing also free service even for their communities. Okay, so it's all about advocating about the impact of the private providers. That's what we did in Ethiopia.
Great, thanks very much, Tesfai. Daniel, another quick fire question for you from Santika. How do we ensure quality services in the clinic? What parameters are being used in your case in Myanmar to ensure that service delivery is of the highest possible quality and continuous improvement is there?
Good question. So within the scheme we're using, it is one of the risks of using a capitation payment is it can lead to lower quality because you pay a fixed fee to the provider for the service. So what we've added on is a performance-based incentive scheme that uses quality measures as a way of adding to the money that the provider can earn as long as they pass our stringent QA processes. Unfortunately, so far the main providers we've worked with have been some of the best providers we have, so we've not necessarily been able to prove anything, but that will come as we expand.
Great, thanks very much, Daniel. And I'm going to go for the final question now from John De Flavier, who specifically speaks about the importance of availability of additional capital. And the question is this: for social enterprises needing additional capital, particularly from commercial financing sources that were mentioned by Tesfaye in his presentation, are they able to access financing at reasonable interest rates, perhaps up to 5%? John, he mentions that offerings for financing for social enterprises are often in the range of between 7 and 70%, obviously prohibitively expensive for many of these social enterprises. So Tesfaye, can I put this question over to you in the Ethiopian context?
Yeah, great question. Yeah, with regard to the social enterprises, or in our cases, a workplaces program, what we did is just we do a kind of return on investment analysis. Okay, we did an investment analysis just to get buy-in by the employers or the owner of the enterprises. Okay, in previous time they expect the family planning program is fully funded by donor, and they expect us a free product distribution and free family planning service provision in their workplace program, though they invest a lot as an investor. So later, after we do a return on investment, how might they earn by investing in a family planning program premises, and then now they become more interested in also to secure budget for family planning programs. But actually we didn't yet determine the cutoff proportion of how much percentage that goes to this investment. But in 2017, what we did is thoroughly analyze the return on investment for each enterprises or our workplace programs.
Great, thanks very much, Tesfaye. And I'm afraid that we're at the end of this Q&A section. We're right on time, but just a quick comment from me. We have a question from Mirel from Mexico that we will ensure, Mirel, that question is answered. Ados and myself are taking note of these questions. We have further multiple questions posed by Smarajit and by Sarah that will also ensure get to the relevant panelists and receive an answer in the next few days. So the recording of this webinar will be shared tomorrow with participants from this webinar, and you can also find it on the FP Highimpact Practices website. If you scroll to the bottom, you'll see a tab on webinars, and you can find it as a social franchising webinar there. Just to draw your attention again to the handout section in the right-hand navigation, where you can grab the relevant documents that Daniel referred to. The brief is there as well, of course. The brief is on the website, and the presentation that we've had this morning is also available via the website. So for more information, the FP Highimpact Practices website, of course, the IBP initiatives details are there, and FP 2020, who jointly presented this webinar to you. It just falls to me to thank you all very much, including staying on with us for an extra 3 minutes. And to thank, of course, more than anyone else, our panelists, Sarah, Daniel, and Tesfaye, and my colleague Ados May, for bringing such an excellent webinar together. And we look forward to engaging with you further on social franchising as a very exciting way of advancing family planning goals in your countries and indeed globally. Thank you very much. Good morning, good afternoon, good evening to you all.